33rd year of working in critical care. I work at North Shore Evanston Hospital, and that is basically my home. And after 30 years of practice, what I've found is people can't talk about these things when I'm taking care of them. We need to talk about these things when we're fine, when we're healthy, when we're in the community, and this isn't an issue. And I became very passionate about this and decided I want to start talking to people about what I see every day and how I can bridge the gap between what I know and what the community might not know. So that's why I'm here. This is the impact if you don't talk with your physician, your family, get paperwork in place. It could happen that you're driving down the road and become in an accident and then you're having surgery and, you know, for a number of things happen. And I just happen to be addressing a senior event, a community event now with Elderwerks, but I take care of patients that are 20s, in their 30s, in their 40s, right? They're on their bicycle riding and get hit by a car. I mean, traumatic things happen to young people. And usually as we get older, more disease processes that are chronic start getting worse and worse, or an acute illness happens and it gets out of control. So if that call comes and your brother, your husband, your son, something happens and you haven't had a conversation, I'm taking care of you and I say, you know, well, what does Joe want? And I hear, I don't know. We never really talked about it. I mean, I don't really know what he would want. And then family has to guess, right? The burden of not knowing what to do is tremendous. And I see family members who, they can't eat, they can't sleep, they feel like the whole weight of this is on them. And, you know, that only makes it more difficult to think about things with a clear head when you're very stressed. Indecision can lead to prolonged treatments. And what that means is sometimes people are so paralyzed by making the wrong decision, they can't make any decision. And everybody's telling them, you know, this one calls from out of state, he says do this, and, you know, I mean, it's overwhelming and they're just kind of frozen. I can't make any kind of decision because I don't want to do the wrong thing. You know, someone else decide for me. Or I'll tell you in 2 days. Give me till next week, Thursday. And in the meantime, someone could be undergoing treatments that they really never wanted in the first place. I cared for a 30-some-year-old person, and I very much try and protect the privacy. But this person was a free spirit, followed the Grateful Dead around, liked to have fun, not married, in their 30s, and literally was hit by a car. This person was hit by a car. Traumatic brain injury. And their parents said he would never want this type of machinery, equipment, breathing tube. But we can't take this off. I mean, he's such a free spirit, but then on the other hand, they're like, we know he wouldn't want it, but then they couldn't remove anything. And if this person had made it really clear, if anything ever would happen to me like this, you know, traumatic brain injury, I'm never going to be myself, please don't keep, like that would have at least been something. And even if the parents still didn't want to take any machines off, you know, I mean, it would just be something that was there in writing that they can say, okay, he made the decision. I'm not making the decision. This is his decision, and he's communicated it. And now we know moving forward that we're doing what he wanted. And it takes that burden off of that person's shoulder because they're not making the decision, they're just speaking for the person who can't. And I try and make that distinction with my patients' families when we're in those situations. You're the voice for them, you're not the sole decision maker. Families can feel guilty, frustrated. They're not, you know, they don't have an answer in front of them. They don't know if it's right. And oftentimes the medical team would say what they would do from a medical perspective. And in my years of experience, all the different specialists give you the opinion of their own organ system that they work with. So the neurologist is going to tell you for the brain this, and then the pulmonologist is going to say for the lungs this. The infection disease doctor will say, well, as far as the overwhelming infection goes, we're going to put them on these antibiotics. And it's, you're getting little pieces of information from all the specialists, and usually it's let's go, let's go, let's go. And, you know, having information like this, where you can say, you know what, I'll do that, but we're going to do it for 2 weeks, and we're going to put a time limit on it. And if Dad's not better in 2 weeks, he told me he doesn't want this kind of stuff. Now you've had that conversation with Dad before, and you know, based on the information you're getting, we're not giving up yet, but we are going to set some time limits because Dad doesn't want this to go on. So knowing how to have conversations and that there are choices and that you can ask for that type of information, it helps. So, we don't know what's out there, what's going to happen tomorrow. We've been really lucky so far not to be in these situations. It is too late to try and really talk about it when a crisis situation has happened. And if you're unable to speak, you can't tell us who is going to speak for you. And by default, someone in your family is going to make your decisions. So I've taken care of family members. I was just talking with someone, I don't know if this was at lunch or if this was yesterday with someone. I've had a patient who's not divorced, but they're separated. They've been separated for 8 years. And the kids want to make the decision for Mom, but they're not legally divorced. So as far as the surrogate act goes, Dad's next to make decisions, even though Dad's not been in the picture for 8 years. So unless a person has named who is going to make decisions for them based on what you tell them, who you want and don't want, there is like an order of who speaks first, who makes the decisions first, then second, then third, then fourth, because we try and reach any family members. One of my best friends has family they're very dysfunctional and alcoholics in the family, and she's like, I don't want any of them making my decisions. I don't want anyone in my family. So she had to name someone that wasn't in her family to make those decisions. So just some things to think about. And in general, with decision making when it comes to healthcare, if you think about how you make decisions now, how do you decide what car you want to buy, or when you want to paint the bathroom, do you do it like this? Or do you need weeks to put all the different colors up and to take a while and mull it over and look at it? You're going to have to make decisions for your care, and at some point, if you have this conversation with your family, with your healthcare provider, and have it that one time and get those things ironed out, then you can just kind of put it on a shelf and know that that's taken care of. You can revisit it maybe once every year or two and see if there's any big changes to what you think. Some people that have chronic illnesses like heart failure or COPD or some, there's a steady decline over a lot of years, but at some point there's going to be some tough decisions to make as the organs really start to fail. And having a conversation up front and hearing, 10, 12 years down the road, you may be facing this. What are your thoughts about that? And then revisiting that every couple of years. That makes a difference versus I need to know now, are we moving forward with putting a trach in? Are we going to put in a feeding tube? We can't, we really can't delay any longer. We need those decisions. And so it helps to have had conversations in the beginning along the way. And I like the picture in the grocery store because that's me if I am hungry and don't have my list versus if I'm full and I have my grocery list, right? I mean, you make decisions, really, for me, it's easier when I have my list and I know exactly what's going on versus wandering aimlessly in the aisles. Having some thought to how you're making decisions helps. So I thought I'd visit informed consent. And informed consent, especially like if you're having a surgical procedure, what you're asking to sign is that you understand the surgical procedure and that you're giving your permission for it. And the things that should be understood are, why is it that this surgery has to happen? What are the risks that can happen? And what result should I expect as a result of having the surgery? So the indications are helpful to hear and then understand, are there alternative treatments for what you're telling me? You know, what are the indications? Are there other treatments that I could use before I actually have surgery that I could try? You know, some physical therapy or occupational therapy, or is there anything else that I can do, other types of medications? Is there anything less invasive that I could try before I actually have surgery? And what will happen if I don't have this operation? Can you spell it out for me? How long before you think I'll be back here seeing you again? Or what can I expect to live with because I'm not going to have the operation? You know, these are questions that can be asked if you're looking at a surgery. What are the basic procedures that will go on? What kind of, you know, for like open heart surgery, that's a big one. You know, what are the things that they're going to be doing? What will I expect when I get out of surgery? What's recovery going to look like? Do I have to have family there to take care of me? There's a lot of questions to ask, and especially the risks, because, you know, people, medical personnel, they're so used to just quoting the numbers off the top of their head, 3 to 5% risk of this, less than 2% chance of that. You know, really have to listen, because if you're that less than 2% or the 3 to 5%, you want to know what a risk of what, and clearly understand that before you agree. And there's been a trend moving towards patient-centered care with shared decision-making. These are like buzzwords, if you will, for healthcare now. Instead of it being a paternalistic, you know, I'm your doctor and you need to do this and we're going to do it next week. So Tuesday, clear your calendar, getting this done. You know, now it's more having a conversation. And it really does happen sometimes, but it's taken a while to change the ship around to look at these conversations differently. You know, what is it that you want for your health down the road? Is it okay that you might not be able to walk after this? You know, is it more important that you're able to go skiing every winter with the family? You know, kind of hearing what are the things that you want to be able to do? What's important for you? What do you value? These are the things that you want to achieve with your health versus what I or someone else as a medical professional is going to tell you you need to have and why you need to have it, because we might not be eye to eye. And then I think that's why people don't always comply with medication regimens or following up with treatments and things, because they were never really 100% on board when they were told what the treatment plan is going to be. So having some conversation and knowing that it's okay to say, no, I don't think so, I don't want to take steroids, I got nothing against steroids, or whatever, you know, whatever. People have different reasons all the time why they do and don't want to undergo a certain treatment or therapy or surgery, and it's okay to have these conversations, and it's okay to want this, you know, it works better if both sides are heading towards the same goal. You know, my dad, he's passed away, but he struggled so much with his knees. And I was like, Dad, just get the knee surgery done. Wouldn't happen. But we had different ideas. I thought he needed it, he didn't. So, you know, you want to be heading in the same direction with your healthcare provider. I didn't know if everyone knows that there's a patient bill of rights. So anytime you go into a facility for healthcare, they have a bill of rights, and these are some of the rights that you're entitled to as a patient. You have the right to information that's accurate and easy to understand. And if it's not, you have the right to keep asking questions and to have other people explain it to you, and do not sign something unless you really understand it. If you want someone else to hear it and talk with you, say, you know, I've been with my mom and she goes to the doctor and she'll say, I want my daughter to hear this before I decide. And so, you know, get on the telephone and have a conversation, and she'll say, what do you think, Care? And, you know, that's okay to do. Language barrier at least in the hospital system, we have to have interpreters for everybody. I had 3 different languages in one day that I had to have use interpreter. We've got a computerized stand that we roll in the room. You just type in the language and a person comes right on, and you can have conversations in whatever language the patient has. The more information you have and the better you understand it, the better you are at making informed decisions about your medical care. There was just something I posted about patients that have chronic hemodialysis, and some of those patients are refusing to continue with their treatments. And there was an article about it in the newspaper because, you know, they have information, they know about their disease process, they've been doing this for so long, and they're done. They're tired. They don't want to do dialysis anymore, and having the right to just say, I'm finished with my dialysis. Just came to my mind. Choices. You have a right to choice for your healthcare provider. It is absolutely 100% okay to decide that tomorrow you do not want the same doctor and you want someone different. You can just simply say, I'm going to choose another physician or dentist or whoever it is that you're seeing. 100% okay. Just did this with my mom. She's like, you know, I saw the other guy while he was on vacation. I like him a lot more. I said, well, then you go see him. We just let the other guy know you're finished with him and you're moving on. It's completely okay. It happens all the time. And it's okay to get second opinions. It's fine. Respect. You should be treated with respect, considerately. Healthcare providers should be respectful of you when they provide your care. You have the right to participate, again, knowing your treatment, taking part in those decisions, not just being told what we're going to be doing. You have the right to confidentiality, privacy. You've all heard of the HIPAA Act. You do have a right, at least in the hospital setting, to look at your own record and see what it contains, what your results are, what people are charting about you. You have that right. And if there's something in there that's incorrect, you can request that it be edited to reflect the right thing. You have the right to appeals. If you have a complaint with your health plan, physician, the hospital, you have that right to appeal whatever the issue is, and also access. If there's something that you believe to be serious danger, you have the right to have emergency services come take you to be seen without waiting for an authority or financial penalty. So I just didn't know if people really realize that there are a whole set of patient rights when you enter facilities. Then there's also the responsibilities of the patient. I know when I go to see someone new, I don't know them at all, and they've come into the intensive care unit, I need to know as complete information as I can from that person. And if things have changed, if there's any concerns, we need to hear it, even if it's something you don't want to disclose or you feel funny talking about. Sometimes it's important. I take care of patients often who take alcohol or some type of sedation like Valium or Xanax or something like that at home, and they don't tell us that up front, and then 3 days later their heart rate's off the roof and their blood pressure, and then they have just had brain surgery, and I can't figure out why the blood pressure and heart rate aren't coming down. And then someone mentions like, oh, well, he hasn't had his 10 cans of beer that he drinks every night. It's like, so then I can put something into place that treats withdrawal, and then the heart rate and blood pressure come out. So it's very important that we understand all about you, and not just the parts that you want us to know about you. You have a responsibility to follow the treatments, and if you're not going to follow them, to at least say that you're not going to follow that treatment, so that maybe we can work out a different one. Keeping appointments, following the facility conduct rules and regulations. That's big now with a lot of workplace violence in healthcare facilities. And meeting financial obligations, like you would, you go to get your car, you bring your car in, you have to tell them the complete information about your car, any changes, concerns you've had with your car, do the things that you're supposed to do to keep your car maintenance, oil changes, things like that. Meet your financial. I often compare taking care of the human body to the car with pumps and wires and tubes and electrical currents and all this So having some of this information about informed consent and patient rights is basically advocating for yourself and your healthcare situations. Asking questions. You know, I don't know if it's a generational thing, but when I've gone with my mother-in-law and my mom, it's always after we leave the doctor's office that all the questions come. Like, we should have asked those when we were there. Oh, I just figured I'd ask them later. No, you have to ask these questions when you're sitting right in front of the person. Make sure that informed consent, that you really understand all the alternative treatments. What if we don't have any treatment? What are the risks? What exactly are you going to be doing? If you want to see a picture, show me a picture. Do you have a model of it that I can understand it? You know, what am I going to expect afterwards? These are important things to ask. Keeping track of hospital personnel. If you're in a hospital setting and you're there for a little while, sometimes it's hard to keep track of everybody. It's okay to have a journal or some kind of book, and you put down who are you and what do you do, and keep track of people so you know who's giving you what information. And we usually try to have one person be the spokesperson for that patient or for the family, so that we're able to just, you know, it's like playing that telephone game. You know, I tell you, you tell me. You know, sometimes if there's too many people talking to too many different family members, it gets very confusing, and it's nice to have one person that's keeping track of everything. Advanced directives in the chart, which is at the heart of what we're going to talk about, and asking for daily updates. Who's the one person that will call me every day and let me know what's going on with my husband? Who's going to run through everything with me every day? Okay, here's the number I want you to use. I'm his power of attorney for healthcare, and I would like to go over that with you every morning. If you could do that 10 minutes and talk through what the plan is for the day. You don't have to get there, like I see people do that. They come in like 5:30 in the morning. I want to wait and be here when the doctor gets here. I think, you know, you don't have to sit here for hours on end and wait. Like, let's come up with some way that for sure you'll get it. Hear from the doctor every single day without having to come in before the chickens are up to make sure you don't miss them. You know, we can have conversations about that, so that will work. So times when you're unable to speak for yourself. These are some examples. Stroke often can present with a person not being able to speak. Expressive aphasia, or even understand. That's called receptive aphasia. So you could ask someone, lift up your right hand, and it's like I've said, no. They cannot comprehend at all what you're saying. That's called receptive aphasia, but expressive aphasia is the inability to speak. If a patient has a breathing tube, an endotracheal tube or trach, sometimes with the trach you can talk, but when it's new, you can't talk. If you're on the ventilator, you're unable to talk because the breathing tube actually goes through the vocal cords. It passes right between the vocal cords, and air doesn't get through, so you're unable to phonate, to make a voice sound. If you're sedated for any period of time, you're not able to really speak for yourself at those times, and there are many situations where you have to keep someone quiet and sedated, and they might be completely intact in there, but for a time being you have to be sedated, and in those times you're going to have to rely on someone to ask what you would want. Head and neck injuries, often there are problems with speech because of those. Seizures, people are usually pretty out of it after they have a seizure, and when we start all the anti-epileptic medications, they can make people very sleepy and groggy. If someone has delirium or dementia, they can't really speak for themselves or make decisions in those circumstances either. So there are periods of time, whether it's a small window of time or many weeks at a time, where patients are unable to speak for themselves and need someone to be their advocate. And that's where I think the advanced directive comes into play. And I'm just going to talk about advanced directives as if you have this is the first time you're hearing it. So I apologize to people who may already have an advance directive in place. I'm just going to go over the basics of them. It is a legal document. It's requested by any hospital, nursing home. When you come into these facilities, you will be asked by law, do you have an advance directive? If you do not have an advance directive, and this sounds like the police, if you don't have an advance directive, we will get one for you. Like, sorry, I'm just going, my head's going somewhere else. But we will have someone provide you with an advance directive. They don't necessarily go through it with you. They don't follow up to make sure that you filled it out. We are just obligated to give you an advance directive to fill out if you don't have one. We encourage you to do it, but no one's really going to take the time to sit down with you and go over it all with you, unless someone has that kind of time to do that with you, but that doesn't always happen. And it's a way to have your voice heard and have your wishes honored. So there's a big umbrella of advance directives, and there's different parts. The first part is the power of attorney, and we'll talk about these different parts. Naming your power of attorney for health care, doing the actual living will or advance directive. Those two terms are kind of synonymous. Do not resuscitate, or DNR, or, and then, like if you want to be an organ donor, those are typically in all of the advance directive forms. And this was just taken from, I just downloaded this from Illinois' advance directive. So I think it's illinois.gov. But you can print one of these out for yourself and complete it. And this, I just wanted to show you, like this first section is the power of attorney. And what that does is you name someone to make decisions for you when you can't. And that first box says, when I cannot make them for myself, my sister's going to make decisions for me. The second one says, right now, even though I can still make a decision for myself, I'm going to let my sister make all my decisions anyway. Even though I can make them, I want them to do that now. And then she can continue to do that if I can't. And my sister-in-law has a lot of dementia from her family members, and she's terrified what's going to happen when she gets older. So she's named her husband, my brother-in-law, to be her decision maker. So when there comes a time, if there comes a time when if she does get dementia and it progresses, she already has him in place to do this. And it says in here, life-sustaining treatments, and it names them: tube feedings, fluids in a tube, breathing machines, CPR. Those decisions are for the agent is instructed to consider those things and any type of suffering or the quality of their life. That's what this power of attorney form gives that person the permission to do. Listen to all the information, hear how it lines up with their quality of life that they would have wanted, and decide for that person, is this in alignment with what they would want. The power of attorney for healthcare can also access your records. They can have you move to another facility if they're not happy with the care that you're getting. There's a whole list of things that a power of attorney for healthcare legally can do for you if they feel that it's necessary. And they can have, even if they're not deemed the power of attorney for finances, there are some things that they can have access to if they have to apply for disability or apply for other type of services where they might need to access your finances. You're allowed to do that in order to get the health care that you need. So it's important that you think about who you choose and their ability to speak for you. So who you choose it has to be someone over the age of 18. It should be somebody that is pretty close in location, so that if something did happen, they'd be able to be there quickly, versus having to fly in from out of state or have to come in back and forth. It should be someone that is going to be able to speak for you. I cared for a gentleman whose culture spoke to the men mostly, and women were not really the decision makers, and he asked me to come in the room with his daughter, and he said, she's going to make decisions for me. And I said, okay, but she kept telling her dad's brothers, her uncles, what he wanted, and they completely ignored what she had to say. And they said, no, we're going to put the tube in, we're going to do this treatment, we're going to do that. And he had a lot of treatments that I know he didn't want, that he told her, and she did her best, but you know, that wasn't the right choice of a person to name as your power of attorney for healthcare. And she wasn't about to make waves within the family because, you know, no one wants to be in the middle of all of that. It's very difficult. So really picking someone that can speak for you and not for themselves. You know, like when I started telling the story about that young person that I took care of and their parents having to make decisions for his care, he might have done better to have one of his buddies who also went and saw the Grateful Dead with him to be his power of attorney for healthcare to say, no, we talked about this a lot. He does not want any of this stuff. And then, you know, the parents might say like, okay, you know, it's so gray. There's no black and white. It's so gray, some of the things that happen. But just to consider that. So next, taking a look really at the living wills. So paying attention to the details, sitting down with someone who knows this, whether it's the healthcare provider or a legal person. You know, healthcare providers have all the medical background, and our legal counsel knows how to make sure you have your protections in place. So, you know, whichever route you choose, or if you print it down off the internet yourself and fill this out, make sure you're understanding what this says, because this declaration on this day, my desires for my moment of death shall not be artificially postponed. This is if you're deemed with a terminal condition, and if it's determined that death is imminent, that you just be permitted to die naturally. So then I would ask the question, well, if this is terminal and it's imminent, meaning death's right around the corner, why in the world wouldn't you be permitted to die naturally anyway? And I'll tell you from practice, because we have machines that will keep you alive, and you'll die with the machines in place instead of dying a peaceful natural death. We'll put anything in the orifice that works to help you keep going another week, another 2 weeks, another 3 weeks. Whether you're going to wake up and be conscious and know your family, I don't know, but that's what happens if these discussions aren't had, right? And this is a terminal condition, death is imminent, you can die naturally. So then there's also a section, additional statements, I kind of highlighted. Guide for your agent when making decisions, express your wishes. These next two situations are when you're not necessarily terminal with death being imminent. Maybe it's end stage cancer. Well, no, that is more a terminal situation. Maybe there was a major stroke, and this person is never going to be awake, alert, recognize anybody, or have any conversation or walk, but they will be alive. You know, there are those types of situations where if you just want to go on a comfort care path versus aggressive treatment and antibiotics and, you know, everything else, you know, there are risks and benefits to everything we do and don't do when we take care of patients. So there are ways to put your wishes down that aren't necessarily linked to a terminal disease. One of my best friends, I was her agent before she passed away. She was 56 and had metastatic ovarian cancer, and she had 4 brain mets. And she was given the choice of whole brain radiation therapy, blood transfusion because her bone marrow was shot from all the chemo that she had had, you know, and she had to decide, do I get blood transfusions anymore, and do I get whole brain radiation therapy? So there's, you know, it sounds like a menu, kind of, like I want this, and I want that, and I want this, but that is what you have to decide, and it's like exhausting to think about this and to go through these situations. But on the other side, when I take care of patients whose families have had these conversations, everyone comes in and they're all like, oh, no way, he made it very clear, we're not doing this, we're not doing that. I had a gentleman who was 94, he was driving, he still went and played golf. His son was his power of attorney, he had definite conversations with his father, And the gentleman came in, he had a subdural hematoma, which is a bleed in the brain, and he started having terrible seizures, then he needed to be on a ventilator, and then he had an infection and had to get antibiotics. And that was one of those situations where his dad had said, you know, if you see that I'm not going to be the same guy, I can't go back and play golf, and I can't get in the car and drive again, and, you know, I've lived a really good long life. And so his son gave 2 weeks of therapy. He still had terrible seizures. He was on 5 different medications, on a ventilator. He couldn't stop the seizures, and his son said, that's all. Let's keep him comfortable now and just remove all this other stuff. So a subdural hematoma and those seizures weren't terminal, but it was a quality of life that his dad had expressed that he wanted to have. And if he wasn't going to have that, then he wanted to be, you know, allow him to be as comfortable as he could be. You know, some people want to be at home. The friend I told you about, she wanted to die in her grass bed at home, and that was her big goal. And she's like, I just want to be there. And I said, I will make that happen. You know, so then I knew if something were to happen catastrophic, I wouldn't call 911 and take her into the hospital because she wouldn't want that. She wants to stay at home where her cat was and all this. So we did that. So these conversations are, to me, they're not difficult because I live it and I just feel so passionately about it, but to other people, it can really be hard to start these conversations. There's an organization online called the Conversation Project, and it gives you tips to talking to people. You know, if you want to talk to your parents, if you want to talk to your children, if you want to talk with your loved one and they don't want to talk about it, it kind of has some suggestions for how to start the conversations. So the important part then for the advanced directives is getting those details, you know, things that you wouldn't even think about, and making sure it's in writing. And even one step further, even though it's written, really talking to someone about it, you know, and not just superficially, but really getting into the details. Sometimes, you know, if you see a movie, you read a book, or after hearing this conference, you say, you know, I listened to this person talking about advanced directives, and I don't think we ever really sat down and had a conversation about this. I'd like to do that because I know you want to talk about it, but I need you to know these things just in case. You know, and have these conversations, write it down. The CPR, DNR, do not resuscitate, CPR. CPR came to be for cardiopulmonary resuscitation. Someone has a massive heart attack, their heart stops, do CPR to get blood flow going again until they can get medical treatment. CPR is not necessarily when you're very sick in a hospital with all these comorbid conditions and then your heart stops. That's more like, you know, more a it's very different from CPR to save this life if they're having a heart attack. That's more, you know, you have to think about what are the chances, the likelihood of recovery. The American Heart Association recommends to healthcare providers when having these conversations in the hospital to make sure people know, like 10 to 15% of patients survive CPR in the hospital. That's it. And they're in the hospital. They're getting it right away with all the stuff that we have. Because usually they're in the hospital for a reason that might lead to one having a cardiac arrest versus walking down the street or sitting at home and, you know, playing with the kids or something and then you have a heart attack. That for sure, you want CPR right away to try and restart the heart and open up the coronary artery or fix a valve or whatever it is that was the problem. An arrhythmia, and take care of that. So that's something to talk about with your healthcare provider as well. And we, in a hospital setting, every single person gets CPR. Doesn't matter your age, what you're in with, or anything. If you do not have a DNR order placed by a physician in your chart, you will get CPR. And unfortunately, you know, being a nurse practitioner, I didn't have the medical model of training. I was trained as a nurse and then went on for more schooling, my master's, then a doctorate, and I can diagnose, I can prescribe, I can treat, but I learned in a different way. So I feel like I can speak to families a little easier than sometimes I'll hear the physician go in the room and say, if your heart stops, do you want us to do CPR? Do you want us to pound on your chest if your heart stops? You know? Oh my gosh. You know, there's a way to have these conversations. And I think it's something to discuss with your healthcare provider or anytime you come into the hospital, because when someone says to you, do you have advanced directives? One of the following questions will be, so if your heart were to stop or you were to stop breathing, do you want us to do CPR? And I just think that just sounds like such a lousy question. And you know, you're like, well, I just came in to get my knee surgery. You know, you're thinking, geez, what's going to happen here at this hospital? Do you guys can we have found out my heart restarted if it stops? You know, but those are questions we have to ask, and I think we can do a better job of having conversations about it. That was my point there. And then organ donation. If you want to be an organ donor, besides just registering with the DMV, there's an actual website, and then if you don't use the internet, that's hard too. But I've had patients where the back of their card says they're an organ donor, and the family's saying, no, they're not. They are not. They're not doing that to my son. They're not doing that to my husband. You know, and if that's truly what you want, that has to be clearly communicated, and then you name the person who will do that for you so they can be your spokesperson in the event that that happens. But none of us would ever, in the medical community, put the family in that position where we would say we're doing organ donation whether you want it or not because they said so. Or we wouldn't do something like that because that's too traumatic. You know, if there's that much dissension between the family, no one wants to do anything that would further add fuel to the fire. So, you know, this is why there's these gray areas and these discussions are so important. If it's something you're very, very passionate about, that you want to be, as someone told me, she's like, oh, my sister, she had 3 liver transplants and she eventually passed away, but she always wanted to be recycled, and her return was recycled. So, you know, if it's something you feel very strongly about, you have to communicate that with people and name the people that will honor that for you. So 5 Wishes is a document that I personally would recommend if you're looking at what to use. This is something that you can get from, I'm going to say Dignity, I'm blanking right now. Aging with Dignity, agingwithdignity.com, Aging with Dignity. This document was prepared by a journalist who traveled with Mother Teresa, and they were at, I think for a year, he followed her at an AIDS clinic in New York where she was working, and he drafted this with legal people because these are the things that were important to patients that were dying. The person to make the medical decision, which we already talked about, the power of attorney for healthcare, the kind of medical treatment you want, and it goes into much more detail. Terminal illness, stroke, something that's not a terminal illness, if you're in a comatose state for a while, and it looks to be extended for a period of time. But then these 3 other points were added into this document. How comfortable do I want to be? You know, would you rather have a lot of pain medication even if you're going to be sleeping, or do you want to be more awake so that you could be interacting with family members around you? Do you want people like to bathe you and keep you clean all the time? You just want to be left alone because you don't feel good? You know, do you want people coming, how you want people to treat me? Do you want people coming in and saying prayers with you? Do you want music played at your bedside? Do you want, whatever it is, you know, anything that you really want and how you want to be treated. You know, when my dad had a cardiac arrest on a Friday evening, and we took off the machines on Sunday, and he stayed alive through the next week until Saturday. And my aunt is she's very, very religious, and so she was doing a lot of things that it wasn't what I would want, and so I would just kind of step out and, you know, but it's something that was important to my mom and my dad, and so, you know, there are things that if you want, you know, have a priest come in, have someone, whatever it is that you want. I cared when I was in another part of the country. We had a very large gypsy community, and they would put like someone underneath the bed onto the ground. They wanted to get their body close to the ground. So there are different things that are very important to people. And then what you want your loved ones to know. You know, if something were to happen and you didn't have that moment to talk to your grandkid, you know, what would you want your grandchild to know? And you can leave that in a written message in here. If you wanted, you know, my mom tells me I want this one song at my funeral played twice because she likes the song so much. So all these little details is something that can be in this document. My friend with the brass bed, you know, that was in her 5 wishes. It's an excellent tool. Palliative care and hospice also are mentioned in that, and I wanted to talk about it now. If you don't know the difference between the two, palliative care is used to treat symptoms while we're still curing, we're still treating, we're still doing all the medical therapies that we can. Where hospice is, we've decided now, we're just going to let death occur naturally and keep the patient comfortable. Palliative care is like for someone who has a lot of burden of symptoms. You know, I really want to get in my car and drive, but I get so tired, or you know, my legs are hurting, or you know, I want to stand up and do something in the kitchen, but I get so breathless. You know, and so they'll talk, how do we manage those symptoms? Maybe they're having a lot of GI nausea, and so they'll come in and try and work with the symptoms to help manage it while you're undergoing treatment still. So palliative care is something that I encourage people to ask about early in the beginning to help manage symptoms. And hospice is now we're switching gears, and we're going to keep someone very comfortable and bring everyone in, you know, whatever that person wants for comfort before they pass. And I thought it would be interesting just to show some of the things that we do in ICU, in case you've never seen some of this. In the top left corner is an endotracheal tube. That's a breathing tube that goes down when we put someone on a ventilator. And one end sits in the trachea about here, and the other end is out of the mouth about this far. And then next to that is the picture of the ventilator, and that's the machine that's hooked to it. Sometimes we use ventilators for an hour or two, sometimes they're on for weeks and weeks at a time. CPR, these are some decisions that may have to be made in a hospital setting. The CPR, the defibrillator, that's the electrical current to restart the heart or to help with an arrhythmia. The thing in the top right, an intra-aortic balloon pump, it's kind of hard to see. It's threaded into a femoral artery and goes up into the aorta, and it pulses literally a balloon, inflate, deflate, inflate, deflate, inflate, deflate, and it helps shuttle blood in the aorta to ease, I can't talk without my hands, to ease the work that the heart has to do. In the lower left is a picture of what's called a ventricular assist device. This is offered when patients have very severe heart failure, and it's something that you can live with at home. You plug yourself into the wall at night, literally, and then in the daytime you unplug from the wall, and you've got battery packs, and that's what's on the side and like the holster things. There's batteries, and there's an actual inside your chest cavity, a device that acts as your heart, and people can survive with that. It's got a lot of responsibility going on with that. There's a big responsibility for how to care for that and what you can and can't do with that. But you know, if someone's heart failure is getting bad enough, there comes a point where they say we'll give you a ventricular assist device. Maybe you can't have a heart transplant, but this can give you a couple more years, and it's a big decision. Next to that is a continuous dialysis machine. We use that on patients that are too unstable to have conventional dialysis. This is a slower, gentler dialysis over 24 hours versus 4 hours of regular dialysis. And then surgery, transfusion, like I was saying with my friend, her bone marrow couldn't make blood anymore, and so she had to go to the hospital for transfusions, and she was finished with that. And then just food, water, you know, feeding tubes, IVs to keep hydration. These are all kind of decisions that people might have to make within a couple of days. You know, are we going to do this? Are we going to do that? Do we want this? We want to try that. It's a lot. And then to think about the quantity of years or the quality of how you want to live. And I just had a couple questions. You know, what is really important to you as you think about these things? If you had What effect would a serious illness have on your family? If you were to lose X or Y or Z, at what point would you say, I don't want to do this anymore, I just want to be comfortable? Are there situations that you would think you wouldn't want to live anymore if you were in? What are your religious or spiritual beliefs about this? How would you like to live and where in your final days? What is like a good death? What does that look like to you? Most Americans say they want to be at home, but that's not what the numbers are. It's usually in a facility. So to wrap up, I do believe that completing advanced directives, talking about it with your family, talking about it with your healthcare provider, these conversations are covered by Medicare visits with your provider. If you say, I want to talk with you for 30 minutes about my advanced directives, they're covered by Medicare. If you say, I want to meet again for another 30 minutes because I still have more to talk about, that will be covered again by Medicare. So you can do this. And then if you are ever unable to speak, then you at least have someone that's named and knows basically what you would like. Thank you.